My name is Kelly Batley.
My name is Clay Thompson.
My name is Neil Mowney.
We are MRHFM, a national firm with 70 attorneys and 11 offices across the U.S.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
At Bristol Myers Squibb, we believe that a single touch has the power to transform, to help make every day better, fuller, happier, healthier. So we are always working, proving that innovation and compassion work best hand in hand, developing clinical trials that better reflect the communities we serve, ensuring that every breakthrough reaches those who count on them the most, striving to change the world, starting with a single life, yours.
At Novacure, we strive to extend survival in some of the most aggressive forms of cancer through the development and commercialization of our innovative therapy called Tumor Treating Fields. Novacure is pleased to partner again with the Meso Foundation.
Hi, everybody. Thank you for being on this episode of MesoTV with me today. Today we have Dr. Joseph Friedberg, and I am going to have him introduce himself and tell us where he's from.
Hi, everyone. So I'm here in Philadelphia. I work at Temple and Fox Chase. I've been around though. So I trained up in Boston at Harvard, and which is where I got interested in mesothelioma, working with Dr. Sugarbaker, and then came to Pennsylvania after my fellowship, and a long time ago now, 1996, I started at University of Pennsylvania. I was there more or less for almost 20 years, went to the University of Maryland for 5 or 6 years, and missed my kids too much. and also just a tremendous opportunity to do some exciting work here in Philadelphia, especially with some of the oncologists and researchers at Fox Chase. And so I came back to Philadelphia and been here about a year.
Wonderful. Thank you so much. So that leads us into my next question is, tell us a little bit about the program that you are co-directing at Fox Chase.
Sure. So it's my position, the title is Thoracic Surgeon in Chief for the Temple Health System. And so that includes Temple University Hospital, Fox Chase Cancer Center, and then actually there's a hospital physically attached to Fox Chase called Jeans Hospital. So, and then there's a couple other places, but we don't operate in those. And so, we see patients at both Temple and Fox Chase, but we have our mesothelioma program, which I co-direct with Melissa Culligan, with whom I've been working for, 25 years, God bless her. And so we've actually started a number of mesothelioma programs. We started the Penn Mesothelioma program with Dan Sturman many years ago. It may have actually been the very first kind of fully comprehensive mesothelioma program, I'm not sure. And then we went to University of Maryland, where we started another one, and now we're starting this one. And we're just kind of takes a while to kind of settle in, but we're really actually just getting close to having our formal launch. And we will, we should be doing that in the very, very near future, but we have been meeting already. So the program is us, obviously. There's other thoracic surgeons who are involved and attend. We have the medical oncologists, and I must say this is just one of the most astounding collections of medical oncologists with whom we've worked. But Marty Edelman, Hospor guy, Jessica Bauman. I mean, it's a Joe treat. It's a really terrific, and a lot of them have a lot of mesothelioma experience, which has been great. In fact, Dr. Edelman, who's the chief of medical oncology at Fox Chase, was actually at Maryland. And one of the reasons I wanted to come back, he headed our medical oncology for our mesothelioma program there when they had it. Then we have our radiation oncologists. We have our thoracic oncology nursing, which Melissa Culligan leads. She actually, I think, was one of the first presidents of the International Thoracic Oncology Nursing Foundation, which she just told me yesterday, I think has grown from something like the 12 people who started it to 700 or 800 people now, which is pretty spectacular. Yeah. It's a big, it really brings a lot. We have a lot of international connections through that, which I found very, not just educational, but good for the patients. We've learned quite a bit through her connections. We have nutritionists, we have cancer psychology, psychiatry, we have palliative care, physical therapists, and then pulmonologists. And that's one of the great things about this position. We not only have, and I've worked a fair bit with some really accomplished pulmonologists in my cancer practice, but they've always been very much focused on interventional pulmonary medicine. We have our thoracic oncology program here actually combines the Temple Lung Center, which has just a group of world-class pulmonologists. We have the largest lung transplant program in the country. And so so we have just a degree of kind of general pulmonary knowledge, lung sort of health and interpretation on scans that I've never really appreciated. It's just been amazing for our patients to have someone look at a scan and say, geez, you should be thinking about this, this, and this, which when you're focused on cancer doesn't really come up as much, but really has been incredibly useful. And that I didn't anticipate that, but it's really been a tremendous boon for our practice and for our patients.
Yeah, that's really exciting. Very exciting to have all of that at one place. I mean,
it's great.
That's great for patients as well as for the doctors to have everybody to bounce that off of.
Well, it's the only good thing about the pandemic. When I was at Maryland for a number of years, I was trying to get a telemedicine program started, and just kind of ran into 1,000 points of no. There was this, and then all of a sudden the pandemic hit. So we have our tumor boards now are virtual for the most part. And for instance, where we're presenting our mesothelioma patients now, we'll have as many as 60 to 80 people on.
Wow.
So yeah, it's
that's
a lot
exciting.
And it just, so you have a medical oncologist who has kids, she has to get off to school, but she can join in. And it's just been incredible, the attendance on this. And I have no doubt. And we've had oncologists and pulmonologists present their patients at our tumor board. And that was nearly impossible before. So that's really been terrific.
Yeah, that's wonderful. So let's start with, can you describe for us, for a patient's point of view, what is pleural mesothelioma?
Sure. So, well, in the most literal terms, pleural mesothelioma is a cancer of the pleura that affects the mesothelial cells. What does that mean? It sounds like a lot of gobbledygook. The pleura is the lining of the chest cavity. And so the lining is formed by cells called mesothelial cells. Mesothelial cells line several cavities in the body. They line the chest cavity. They line the pericardial cavity, which the two lungs sit inside the chest, and then and they're in separate spaces. And a lot of mesothelioma patients the presenting symptom will be they develop fluid in the chest cavity, it compresses the lung, and they get short of breath. But the reason it doesn't fall into the other side or go into the other side is that, at least in humans, the two chest cavities are separate. And separating them is a region we call the mediastinum. And the biggest thing there, obviously, is the heart. But the heart isn't just flopping around in there. It's actually contained in this leathery sac called the pericardium. The pericardium is lined with mesothelium. Then the lining of the abdominal cavity, called the peritoneum, that's got mesothelial cells. And then actually the tunica vaginalis, basically there's an area in the testes in men that has mesothelial cells. The mesothelium, just like any cell in the body, lung cancer, you can have squamous cell cancer, so that's like the skin elements in the lung. Those kind of cells, they can develop a cancer. Adenocarcinomas, people hear that term. That's a cancer that develops in the glandular elements of different organs, including the lung or salivary glands, wherever, the colon. But mesothelioma is a cancer of the mesothelial cells, and it's a very rare cancer. So that can start in the lining of the chest cavity, which is the most common since it's usually caused by asbestos, and you inhale the asbestos more often than not. It can occur in the lining of the abdomen, it can occur around the heart, and it can occur in the testes. So those are sort of the four places where there are mesothelial cells, and those are the four places where you can get a mesothelioma.
And when you're looking at pleural mesothelioma, because I get this question a lot, does it look different than lung cancer? Is there something that sparks you to know that there's a difference there?
Oh, it's a huge difference. So lung cancer, I'll draw a picture for you. Let's see. My mom was an artist, and I can barely draw a lung, but I'll do the best I can here.
We appreciate your artistic abilities.
No, you're speaking a little early, but let's see how it goes. I don't know if this will turn up on Zoom here, but can you see that?
Yeah, very well, actually.
Okay, actually, let me turn it down a little bit. So this is like if you open me up like a book, this is what you would see. So your windpipe, it comes down the middle and it splits into the right and the left sides. And so you have the left lung here, the right lung there. This is the diaphragm, which is your breathing muscle, and that separates the belly from the chest. These are the ribs. And then this is what I was talking about. So the left lung sits in this cavity, and that is separate from the right side. And separating those two is you got the heart in the middle. So you have, let's see if this is still in view here. So you have the heart in the middle, and this is that sac I was telling you, the pericardium. This is the diaphragm here. And so lining each of these cavities is this membrane, the pleura, and that starts here kind of at the root of the lung. Actually, let me back up. The other things in the mediastinum separating these two sides, you have your esophagus, which is your swallowing tube, which goes down to the stomach. You have the spine. You have the nerves that work the diaphragm, your breathing muscle. They run on either side of the pericardium. That's that sac around the heart right here. You have all the major blood vessels going in and out of the heart. All those things are in the mediastinum and separating the two sides. This membrane, it starts here at the root of the lung, and it goes along the mediastinum, coating all of those surfaces. Then it goes along the diaphragm, your breathing muscle. Then it comes up along the ribs, along the chest wall here, to the top of the chest cavity. Then it comes down along the main windpipe, the trachea, and the top of the mediastinum here. And then what it does is it folds back on itself to coat the entire surface of the lung, right? And the reason it does that is embryologically, the lung starts here and then it buds out. And when it goes out, it's like pushing your finger through a balloon. It takes that membrane with it. So the pleura folds back on itself when the lung pushes out into the chest cavity. So that membrane, it comes down. The right lung is the larger of the two lungs, and each lung is comprised of smaller units called lobes. And so it goes between the upper and the middle lobe, and then it coats the surface. It goes between the middle and the lower lobe, and then it comes down and coats the bottom part of the lung. and then it comes up here and folds back on itself one last time to complete the circuit. That is the pleural lining. That has the mesothelial cells, and that's where that cancer starts. So that's what mesothelioma is a cancer of this lining. And so it's the hardest thing for not just patients, but almost anyone to kind of wrap their head around. When we think about a cancer, we typically think of something,
solid.
Yeah, you think of something solid. So the left lung kind of has two lobes. So if you have a lung cancer here, that's what it'll look like. You'll see a nodule sitting in the lung like that. And mesothelioma, it's like somebody just poured the cancer in there. And so there isn't, all those structures I mentioned, there isn't a square inch in this chest cavity that's not involved with this cancer. Everything there is cancer. And so that there's a number of implications related to that. So the short answer to your question, Shannon, is yeah, there's a big difference. When you look at an X-ray or a CAT scan, basically if it's a lung cancer, you'll see a nodule for the most part. So it's like a grape sitting in the middle of a Jell-O mold. This is totally different. It's like somebody poured cement in there and it just forms a cast of the entire chest cavity. So it's all these structures. So what you'll see is it'll look thick. That pleura is normally, it's that thick. It's like a sheet of paper. Normal pleura you can see through.
Oh, wow.
It's that thin. This can get, I operated on a patient last week, the cancer was, my God, it must have been close to 3 inches thick down here. So it looks totally different. The hard thing to conceptualize about this cancer is the fact that it lines all this. It's a different thing to treat. So this cancer, if you have a lung cancer up here, if that hasn't spread anywhere, if it hasn't spread to the lymph nodes and it hasn't spread through the bloodstream, whether it's me or anyone, any thoracic surgeon, if we go in there and we take out that lobe of the lung, you can take that out. So you got the cancers in the middle of this thing, and you can take it out, and it's surrounded by normal tissue. If it hasn't spread, you can cure someone with surgery. And that's a totally different situation than this. The term that we use in surgery, cancer surgeries, and we say an R0 or an R1 or an R2 resection. R0 meaning it's a microscopically complete resection, such that if you take that out, there's no cells anywhere. Now, they may have spread already. There's nothing you can do about that, which is why, surgery doesn't always cure, but we treat cancers by stage, and an early stage lung cancer is, all things being equal, going to be best treated with surgery. You take that out, you can cure someone by taking it out. This is a totally different thing. The best you can do here is what we would call an R1 resection, meaning that you remove all the cancer that you can see or feel. So a macroscopic, not microscopic, macro, something you can see or feel, a macroscopic complete resection, understanding that there's still going to be invisible or microscopic disease. Still, there's going to be cells there. There just is. And the analogy I'll sometimes use with the patients is I'll tell them, this one's more like if we said, okay, we're going to spend a day scraping the paint off the walls in this room. And we do, and we come in, we look around and we feel the walls and they're smooth and we don't see anything. But if you go up there with a microscope and take a look, somewhere there's going to be a
flecks of paint.
And it's the same thing here. So even the most aggressive and biggest operations, you're going to have cells left behind. So the implication is that surgery alone really has no role in the treatment of this cancer. And also, technically, surgery is still what we would say is investigational. It's not the standard of care treatment for mesothelioma. And it's because of this relationship of the cancer, we can't do a total chestectomy, to get a negative margin on this. You'd have to take out the heart, all the ribs, the diaphragm. I mean, you can't, At some point, it would become easier to swap heads. You know, you can't completely remove the cancer. So
Everything.
it makes the role of surgery in this cancer much more challenging and to some degree controversial.
With pleural mesothelioma, there are different cell types, and those also can dictate whether or not you are a surgical candidate or not. Can you describe those for us and tell us what makes you more of a surgical candidate? Sure.
Excellent. Let me just turn my light back on. They've timed out. I'm saving money here. Ta-da. Okay. There's basically three subtypes of mesothelioma, just broadly. There's a lot more, but there's the epithelioid subtype, which is about 2/3 of them. And then there's the sarcomatoid subtype. Sometimes patients have heard the term sarcoma. They'll know someone had a sarcoma. That's a cancer of the connective tissue elements, like bone cancers or typically, sarcoma. And they tend to look like these. They're spindle shaped. They're these elongated cells as opposed to kind of more round or cuboid. And then, so there's a sarcomatoid subtype, which is pretty rare by itself. I don't know, maybe 10%, something like that. And then we have, cleverly called biphasic or mixed, where you have elements of both. So you have the epithelioid subtype, you have the sarcomatoid subtype, and it can vary from primarily one type to primarily the other, but you have elements of both. And that's also important. I'll tell you something about that in a second. The epithelioid subtype is the one that we will typically have the most impact with aggressive treatments that include surgery. The sarcomatoid subtype, outside of some sort of clinical trial, there's probably no role for surgery. We're not adding anything. I mean, what are you trying to accomplish with surgery? Well, obviously you want to try and extend life, and then, at least I think, and I think a number of us, I know Melissa shares this, but, for mesothelioma, because the chances of cure with pleural mesothelioma, perineal is a different story, but for pleural mesothelioma, the chances of cure are small. The chances of helping someone are actually, if they're the right person, are pretty high. But because of that, you really, we kind of put quality of life on an equal footing with extension of life. That's really important, which is one of the reasons I've sort of gravitated to lung sparing surgery, saving the lung as opposed to taking it out. I think you have a better quality of life. We don't really, with the surgery, add much in most series, at least with the conventional treatments that have been done in the past, adding surgery to just systemic therapy for the sarcomatoid. And frankly, for most of the biphasic cancers, I think that's changing some with the new immunotherapies and so forth. But for the most part, certainly off protocol, I would say, and ideally all patients should be sort of on protocol if you can. The epithelioid subtypes are the ones who are most likely to benefit from surgery.
So if you have a biphasic patient that is more heavily epithelioid, does that make them a surgical candidate?
Whoa. I'm in the hot seat. The short answer is no, because like I said, surgery is not, if there's different roles for surgery in the field of medicine, right? So if you come to the emergency room with appendicitis, it's a short conversation. You can have surgery, you can die of appendicitis. It's the only treatment, that's your option. If you come in with this, you have this lung cancer here, and they do a whole workup and you're a safe candidate. You just ran the Boston Marathon 2 weeks ago and you fell and you got the X-ray and they found this thing, and you get a PET scan and a brain scan, there's nothing anywhere else. And you say, I don't want surgery. We're all going to look at you and go, well, you don't have to, but what are you, nuts? We know that's the best treatment. This is totally different. This is a totally different situation. This is, surgery is an unproven, frankly. You talk about an insanely rare cancer. It's 1 or 2% as common as breast cancer or lung cancer. A few thousand cases, of which maybe, I don't know the number, 10, 20% go to surgery. So very few patients are having surgery. So you can find a breast cancer series of thousands of patients. A huge series of mesothelioma is going to be 100 patients. 30 to 50 patients is a pretty respectable size series for a surgical series of mesothelioma patients. So we don't have the confidence to say, 28.2% of the time this is going to happen, whereas you can with a lot of other things. That's not the case here. So at the end of the day, I'll spend a lot of time with the patients making sure they understand. I mean, my conversation's always the same. It's, something terrible can happen. To be a candidate for surgery, first and foremost, it has to be safe. So we check the heart function, lung function, kidneys, liver, everything, make sure that it appears safe. Second, it has to make sense from a cancer perspective, which for the most part means it's confined to the one chest cavity, which it usually is. And all things being equal, that it would be the epithelioid subtype. And then the last thing is that I have to be convinced here that the patient understands this is not standard of care. The standard of care is systemic therapy, either combination immunotherapy or combination chemotherapy. That's the standard of care. Anything beyond that as an initial treatment, whether it includes surgery or radiation or anything, any of those non-approved therapies, is considered investigational. That said, there's a subgroup of patients, and this really comes into more of the, especially with this, more the art of medicine than the science at one point, is trying to find people who will potentially benefit from surgery. So what I'll tell them, if I'm ultimately having this conversation with them, I feel that they have this option if they want to do it. And I'll tell them, here's the things that could happen with surgery. One is that something terrible could happen. You don't leave the hospital. That can happen with any big operation. Two is everything goes great, and a couple of months later, this cancer's back like we were never there. That can happen with this. 2022, we're still at the mercy of the biology of these diseases quite a bit, but we know it's extremely unlikely with that. Here, it certainly can happen, and anyone who's done any number of these cases has, sadly seen this. It's heartbreaking. Or the third thing is, if you fall into this select group where this super aggressive treatment makes sense, then yeah, frankly, the most likely thing is that we're going to extend your life beyond what you would anticipate with just the standard therapy, which I will always include in addition to the surgery and things that we do intraoperatively and so forth. So, those are the things you need to do to be a candidate. It has to be safe. It has to make sense from a cancer perspective. At least for me, the patient needs to convince me that they understand, that this is, extreme. And it's always, I've dedicated my career to this because these patients I find just so, I'm motivated by courage. That's my dad back there, and when it was the Army Air Corps, before it was, even the Air Force. And, I've just always been motivated by courage. And this is such a courageous, because the people who go into this having heard that, can you imagine? Like,
right.
Say, yeah, I want to do that. And it's, I want to see my granddaughter graduate from high school. And that's a year and a half from now. I want to walk my daughter down the aisle. She's getting married in a year, Well, yeah, frankly, both those things are unlikely, shy of doing something aggressive to try and intervene. But, it comes with risk and it comes with discomfort. And, the people who do that, they get all of me, because it's really, it's a really courageous group that elects to do that. I probably scare off more patients than sign up. That's just me. I got to put my head down at night. That's the way I do it. We all have our own approach to these patients. But
that's being very honest and realistic, though.
Yeah. I mean, it is. I mean, it's everyone's very vulnerable. There's no one you meet with this where it's not the worst thing that's ever happened to them, right? And
exactly.
and their family, and their families. So, Steve McQueen, King of Cool, he died of mesothelioma.
Oh wow, I didn't know that.
Yeah, he died of mesothelioma, and I think he ended up down in Mexico getting apricot pit treatments, and I mean, you can see how it happens. I mean, any kind of, and anything that's going to help, people will want to, and given, especially this day and age, everyone's on the internet. They see the numbers. They read about it, and so, and I'm sure you hear this all the time. My God, so it's a very vulnerable thing, and it's personally, I think it's really important to be honest, and so
Absolutely.
they know what they're getting into for both of us. And it's a big operation. I mean, the one last week took me 14 hours. Wow. It's a whole thing. So it's a big undertaking, but for the right patient, epithelioid subtype, obviously healthy, smaller tumor volume, like if it looks like this and it's not real thick, that's more likely to be favorable. For whatever reason, women often do better than men. Whether or not the lymph nodes are involved is probably related to it, whether it's invading into things. But like our staging system for mesothelioma really isn't that robust right now. You come in with this thing, and I know if I measure the size of that, it's a lung cancer. I measure the size of it. We biopsy the lymph nodes. We get a brain scan and a PET scan. We'll tell you that's a stage 1A, and this is the prognosis if you have surgery. And there's a pretty darn good chance that's what's going to happen. The mesothelioma, it's more of a wild card, and we don't have such a great, for instance, the tumor volume is not part of the staging system. That's a big deal. The subtype of the disease. So we're talking about sarcoma, purely sarcomatoid patients, at least with the conventional treatments that have been done, rarely benefit from the addition of surgery to their treatment. Whereas an epithelioid patient, I mean, any patient I've had who's, survived for, a long time, they've been epithelioid for the most part. They've been epithelioid. So that's not part of the staging system.
Right.
It will be ultimately. We're in the process of, revising again, but, right now it's not. So like I said, the patient selection is really just so it's critical. It's challenging. And you have to, boy, if ever there was a role for individualized treatments and approaches, it's this cancer for sure.
Absolutely. So I tried to get people to second opinions and referrals, which often leads to them traveling. When someone travels for surgery, what does that look like? How long are they in the hospital? How long do they have to stay in town even after they maybe are discharged?
Excellent question. Depending on what we do, they're usually in the hospital about 2 weeks, I would say. And I would ask them to stick around for probably at least 2 weeks afterwards. We have this, Hope's Lodge here. I think there's a number of them around. They're just wonderful. So, the families will usually stay there, come in and visit, and they can stay there for free. But that's, I'll ask them to stick around for a while. And then afterwards, now this day and age, I'll do a consultation by telemedicine. I mean, we just saw someone from Hong Kong. I didn't make them come out to the waiting room in Philadelphia. So, but when they come here, for surgery, then I'll want them around, figure about a month.
Okay.
Something like that.
Once they go home, what does follow-up sort of look like after that?
Right.
do they normally follow up with you every so often, as well as somebody that's local, or how does that sort of look?
Yeah, so if they come from a distance, we'll work with their local oncologist usually, and we'll invite them to our tumor board, like I was talking about. They can discuss what they were thinking with, our guys, and they can sort of arrive at what's going to, be done post-operatively. And I think that's really important. Obviously, I mean, this is definitely a team endeavor. So we try and loop in their local doctors, and often I'll have spoken with the primary care doctors. There's going to be this or that. You want everyone working together for the patient, so communication's key. But then, yeah, I follow the patients forever, and so they may be seen by other people. And if they get, when they get chemotherapy, I may fall in sync with their oncologist if they're getting scans at home. But my routine is I'll get a CAT scan every 3 months for the first 2 years. The third year, I'll usually transition to, 3 times, so every 4 months. Years 4 and 5, I'll go every 6 months. And then I have a couple of patients who've gone out to annual scans. I'm not that comfortable with it, so I'll tend to scan someone every 6 months after 5 years even. And that's my routine. Again, there's no standard that I'm
guidelines for that,
right?
Along with that surveillance, because I get this question a lot from patients and caregivers, are there markers that they should be watching, certain tumor markers that they should be watching for possible recurrence?
I got to tell you, we have, so there is mesothelin, which, and I got to say, we haven't, we started when I was at Penn, we were following it, and it just didn't prove as useful to us as I had hoped. I was really enthusiastic about it. So right now, I know Dr. Pass has made some discoveries, I think osteopontin, but we have not been following those. Now, we're doing some studies with circulating DNA and that type of stuff, and we're trying to get some studies going with that. Right now, I don't think there's anything wrong with doing that. I don't think there's anything wrong with doing that, but we haven't found it as robust as, we don't have a PSA for mesothelioma. So prostate specific antigen is like, that's just the ideal marker. If it goes up a little bit, we know, this, start looking for cancer. This is bad. This isn't, this rate of that, to my knowledge, doesn't exist for mesothelioma yet, but there are some super smart guys like Harvey Pass working on that for sure.
Yes, that's what I try to tell everybody, is it's still in research, but
Agreed.
they're looking for those.
Yeah, I agree with you, Sharon.
When a person does have surgery, do you recommend that they do some physical therapy as part of their healing process? Do you see a benefit in that?
Absolutely. I mean, part of the conversation is, I'm going to want them up walking, if not the day after surgery, within the day after that. I mean, the more they're up and about, the better. Their only restriction is no lifting for 6 weeks. And yeah, I want them. I mean, some patients do, remarkably well. They don't need physical, they go home, they do walking, they start doing their gardening again. And pretty soon, I'll be getting the kind of 6-8 weeks, when can I start golfing again questions, But if somebody needs it, I'm a huge believer in not just rehab, but prehab. I like them getting in shape before surgery. Mm-hmm. I think that aids in the recovery. And then, yeah, I mean, I want them being active. And, I tell them, if you're a runner, that may not be happening, or you'll be running slower. But if you're golfing, I want to hear that you're golfing again. You're fishing, you're, whatever it is, you're out working the garden, I want a picture of you, planting some, trees or whatever. So, that the whole point of this is for them to get their life back. And so, yeah, if they need physical therapy, they absolutely should do it. There's no downside.
One of the other big questions that I get as sort of a long-term complication that can be from surgery, can you talk a little bit about like neuropathy and neuropathy pain after somebody has a large surgery like this?
Yeah, that's not specific to mesothelioma, that's any kind of big operation, and you can get kind of in the broadest terms, we'll call it, post-thoracotomy pain. So thoracotomy being the incision that's made where you open up the chest and you spread the ribs apart to do the work inside. There's just no way to do this type of operation without, doing that. But a lot of cancer operations that we do in the chest, involve that. And I got to say, it's pretty unusual every now and then. I mean, I tell most patients, I would expect you to be taking pain medicine for a month to a few months afterwards. I've been doing this a long time. I know I look so young, but no, I'm doing this a long time and I don't look so young, but I've never had anyone get, there's a lot of, and rightfully so, a lot of discussion and concern about the opioid epidemic. I've never had anyone get addicted to narcotics after chest surgery. It has never happened. But what I have had happen is patients don't take their pain medicine and they end up not taking deep breaths and coughing, and they end up back in the hospital with a pneumonia, that type of thing. So I tell most patients, I would expect, a month to a few months that you'll be taking pain medicine. It'll be kind of 2-3 months till you're really starting to feel back to being yourself. And it'll be a year or more before a day goes by when it doesn't occur to you that you had an operation. But patients really, they get back to it pretty good. And I would say probably 90% of patients fall into that timeline. I've had patients go home and take nothing. That's rare, but happens. It's usually older women, and it happens, just across my practice, probably a few times a year. And then I'll have patients, taking pain medicine a year later. That's usually younger men. I think we're just not as tough, honestly. But, that probably happens once every year, 2 years. But almost everyone falls into that, month to a few months. But patients get back pretty good. The chronic pain, it does happen. And, I'll usually send them to a pain specialist. Some people think I'm a quack, but you try and learn from your patients. I'll have patients try acupuncture. Mm-hmm. And I learned that from a patient. I had this one patient years ago, and I used to dread her coming in because I felt so bad for her. It was 2-3 years later, and it was still hurting her. And I was sending her to neurosurgeons and pain specialists and another pain. And one day she comes in and she's got a box of candy from what's going on? And I said, she's no pain. I'm like, why? She goes, I got acupuncture. That's all I needed. I was having trouble with my back years ago. It didn't help me, but I tried acupuncture. I believe it. I have a whole box of, can't hurt, may help things. And I think acupuncture is definitely one of them. So when I've had these patients, like you're saying, that are worried about neuropathy, sometimes that's been very helpful. Mm-hmm. But there's a lot of things that can be done, but at least in my experience, it's been pretty unusual.
If a patient has recurrence, I do get the question of, can they have more than one surgery? Is that possible?
Short answer is yes. But again, the reason you need a team is because the way you treat that recurrence is going to be completely individualized. So I will routinely operate for a recurrence within the incision. So mesothelioma loves to grow out of incisions more than most cancers that I'm aware of. So as a matter of fact, that's like a chess game. If you do a biopsy, ideally you'll try and put the biopsy incision in line with the future chest incision for a resection so that you can excise it, because you can sort of eliminate that chance of the recurrence. But the cancer can recur in incisions. If that happens and it's nowhere else, what we'll do is we'll excise it. So we'll take them to the operating room, excise it. I usually mark it with clips so that the radiation oncologist can see it. And that's one of the indications that, at least in our practice, that we've had for additional radiation will then radiate that area. In fact, the patient from the other week, she had her cancer was growing out of her biopsy incision, and it was in a different site. So I excised that and marked it with clips. And so she'll actually end up, so they're from, I think, North Carolina. They're going to stick around, but they'll probably, and that's a pretty short treatment. It was only 3 or 5 treatments, depending on who the radiation is. So they'll stick around probably an extra week for that. But that's one of the roles. As far as going in to take out a big recurrence in the chest cavity, I have done that. It's been highly, highly selected, but it's not like a number of cancers where you'll just go back and So the short answer is yes, you can. There's some situations where I think it's perfectly appropriate and probably, the correct thing to do, and without question, is going to be helpful, like that local recurrence that you excise. But if it's a more diffuse recurrence inside the chest, then I think you're going to start thinking about, is it the same subtype of the cancer? When was the last time they got systemic therapy? You start, was this just in my career, one of the things that some patients have had surgery, they've had the recurrence, and just during the period of time that we bought them a remission, a new treatment has come out.
Right.
And that's, I don't use that as a point to advocate surgery, but that is definitely one of the benefits that I've seen patients. So the immunotherapies, being shown effective for a lot of these cancers, that was not around when some patients that I operated on before have recurred. So that might be something, if they have a recurrence, we would consider that. Using radiation in a selected way is something that we become more aggressive with. And I had a roommate in college who used to drive me nuts. He's a super smart guy, and I'd ask him questions, and he'd go, well, it depends. Always needed more information. And that's the way. So can you do surgery? Yes. Is it the right thing to do? It depends. For the recurrence in the incision, I'd say almost always yes, if that's the only site. If it's inside the chest cavity, that's going to be a more involved examination and discussion.
Thank you. That was a very good answer for something that I get asked quite a bit. So hopefully that will help patients understand that.
Oh, good.
When you have somebody who does have a lymph node that maybe lit up on a PET scan or on an initial diagnosis, can they become surgical candidates with the use of maybe upfront chemotherapy or something like that?
Yeah, it depends. It depends on the protocol. And again, I got to tell you, so years ago, we did, when I was at Penn, we did a trial, and one of the most prognostic features of the cancer was if the lymph nodes were involved or not. And that was with a different set of chemotherapies. And that was when we were doing this light-based cancer treatment, photodynamic therapy. When I went to Maryland, we switched to, and I'm personally a pretty strong believer in trying to do something intraoperatively. Like I said, you scrape the paint off the walls and there's still cells behind. So I can remove all the detectable cancer, but when the chest is open, I know there's invisible microscopic disease still remaining. That's kind of your last opportunity to kind of face the beast directly, so I'm sort of a firm believer in trying to do something intraoperatively. We started doing this intraoperative treatment it's usually used as an antiseptic, betadine. It's usually used as a surgery, but turns out it has a pretty significant anti-cancer effect. And we do that with heated water, and which also kills lyses free floating cells and so forth. So
when you do that, I'm sorry, you're washing the inside with that?
Yeah. So I didn't come up with that. When we went to Maryland, we had planned on sticking with the photodynamic therapy because we actually had gotten pretty good results doing that, as good as anything that had been published. But then when we got down there through logistical things, we didn't have access to the system that you need to do that. And like I said, I wanted to do this. A friend of mine in the UK had published some stuff doing this with the betadine, and we had done that on a few patients when I was at Penn who had not been candidates for the photodynamic therapy for a number of reasons. And so, we switched to that. It's way simpler than the photodynamic therapy. And I had planned to go back to photodynamic, but when we looked at our results, which we're actually writing up now, our last 50 patients, the results are actually better than we got with the photodynamic therapy. So, I stuck with that. So that's something that, we'll do intraoperatively. Lights went out again. Sorry, let me just one more time. Drive me to distraction. That's something that we'll do intraoperatively to try and treat the residual cancer, and then they'll get the additional treatments postoperatively. I digress, though. We got onto the intraoperative treatment. There was something else you had asked me. I apologize.
Oh, that's okay. I was just wondering if you have somebody that maybe has questionable disease outside of the cavity,
the lymph
if they
nodes.
can
I'm
become
sorry.
Surgical candidates.
Right. The lymph nodes we were talking about. Yes. So the point of that, how I got there, I apologize, was in this series, the lymph nodes were not statistically significant in prognosis. So we have not used the lymph nodes as an exclusion criteria. So if somebody has lymph nodes involved, again, we have to look at the whole thing. And I never make these decisions unilaterally. Every patient is presented to the whole group and we have a discussion. I don't just go, oh yeah, let's go to the operating room. I mean, we discuss everyone at length. We go through everything and everyone has to say, yeah, this makes sense. But the lymph nodes, unless they're on the opposite side of the chest cavity or out of the chest cavity, like in the, up in the neck or something like that, that would be an exclusion criteria. It's a crazy cancer, so I would never say never. So if you have someone who's not a surgical candidate now because of a cancer reason, I'll give you a good example is I've had several patients and they actually turned out to be fairly long-term survivors who present. One of my favorite patients ever, and he lived, I think, 10 years after his surgery, presented with metastases into his abdomen. So and I have, so for instance, tomorrow I have a laparoscopy scheduled. If there's any suspicion, and even sometimes if there isn't, we'll take a look in the abdomen, because again, that's a place that mesothelioma can not only start, but it can spread. And you want to be as convinced as you possibly can that it's confined to the one chest cavity. But I've had two patients I can think of off the top of my head, both who survived for actually three, where it was in the belly. So we treated them up front with chemotherapy. And this is before the immunotherapy. So we treated them with chemotherapy. We repeated the laparoscopy, looked in the abdomen. I wash it out, do random biopsies, and there was no evidence of disease. So we offered them surgery and they actually did quite well. Whereas if you were just sort of algorithmic about it, you go, well, that's it, you'll never have surgery. So really try and keep an open mind about this. I've also had patients with bilateral disease, same sort of thing, where if the lymph nodes are not involved, which I would think, at least in lung cancer, we tend to think if you got cancers on both sides, if the lymph nodes in the middle are not involved, it's more often than not, it's this guy started and this guy started. They don't know anything about each other, which is a totally different cancer situation than if this guy spread to that one.
Right.
If that happens, usually the lymph nodes are involved. So we'll look at a patient with bilateral disease. If they're a young, healthy, fit person and they want to be aggressive, I'll consider doing the two sides sequentially. But again, there's a lot of discussion, a lot of thought that goes into that. We just saw maybe 6 months ago sort of the nth degree example of that, we saw a patient who has peritoneal disease and bilateral disease, and he had some sort of, high-tech analysis of all these different cancers, 3 synchronous primary mesotheliomas. This is a mesothelioma, that's a mesothelioma, and that's a mesothelioma, all different as proven molecularly.
So none of them were related. It was not metastatic disease is what you're saying.
Right.
Yeah.
And so normally you'd go, oh my God, he's got mesothelioma in 3 body cavities. Why would you ever operate on that? And I didn't offer him surgery, but I told him, he's doing remarkably well. And in fact, he was scheduled for surgery. And I said, that's another example. I said, personally, I would not, we're not going to make you better than you are right now. I think we should, my God, you just got back from Disney World with your kids, you rode Space Mountain. How are we going to improve on that right now? So, I think we should keep a close eye on you. And that's what we're doing. But if he just had one side that picked up, I would probably certainly consider offering someone like that. He's a young guy, aggressive treatment. So it's totally different. But the lymph nodes in and of themselves are not, at least in our hands, an exclusion criterion. I tend to, all things being equal, with an epithelioid mesothelioma, I'll do the surgery up front and the chemotherapy afterwards, or the immunotherapy afterwards. I know that's also, again, it's not like lung cancer, breast cancer. It's not algorithmic. It's not standardized. I think there's more of a trend to that. A lot of people will do the treatments up front. But I must say that if someone wants to be aggressive, if they have a systemic therapy and they get sick from it, they can go from being, or they have kidney damage, or they can go from being a safe candidate to an unsafe candidate. And the vast majority of the time, unlike some tricky lung cancer cases will do, or a thymic cancer, something like that, even if they have a great response, it doesn't change the operation that you do. Right. You can have a good response with the chemotherapy and go from having to take someone's entire lung out to being able to save half of it. Mesothelioma really doesn't change the operation. So there's not that same kind of impetus to try and, quote, downstage it, which is what we say. And then the other thing is that some patients I've seen will get chemotherapy, and a fair number of my patients I see have already been treated and have progressed through it. And like I said, you always keep an open mind, but some patients will go from, they may tolerate the chemotherapy great, even continue working through it, but the cancer progresses and they'll go from something you can take out to something now you can't take out. So my bias is, if I've had the discussion with them and they want to be aggressive, personally, our group will, for an epithelioid at least, we'll try and offer the surgery up front and then the systemic therapy afterwards.
I think that one of the biggest takeaways from this whole entire episode is that, really getting that opinion from an expert can make all of the difference, because you do have the bandwidth of having those tumor boards and presenting these patients and
Absolutely.
And making the best decisions, because it is such individualized care for each person, depending on what they look like, what their disease looks like, as well as their status in their life. So yeah. My last question is, this is also something that I get asked quite frequently. Is there screening that can be or should be done for someone who may be considered high risk for mesothelioma?
Oh, I wish there. So one of the, yeah, so I'll share a piece of exciting news with you in a second. There isn't a standardized anything for that. So who's at high risk? Well, obviously, people with significant asbestos exposure, bearing in mind that something only like 10% of asbestos miners get mesothelioma. The flip side is, so it's like smoking, right? The overwhelming majority of people with lung cancer are smokers, but the overwhelming majority of smokers don't have lung cancer. It's the same thing with asbestos, and that's the number one risk factor. So that group of patients who have had a lot of asbestos exposure should definitely be getting screen. We have this thing here that our department chair, Dr. Kreiner, started called the Temple Healthy Chest Initiative, where it's part of low-dose lung cancer screening, but there's all sorts of artificial intelligence that also looks for pleural disease,
Wow.
heart disease, other masses in the chest. So it screens for a lot of things. Personally, if I know someone that's high risk, and I'll tell you who defines that group for me, and this is a really tragic scenario that I've encountered so many times now. It's often two sisters who wash dad's clothes, and one has mesothelioma and the other doesn't. And she's like, what do I do? I'll get a CAT scan, just a regular low dose CAT scan once a year for those patients, or if there's something suspicious, more frequently. I think an even better question is, what do you do for those people?
Right.
And who are literally living their lives waiting for the other shoe to drop. And so we just, about an hour and a half before this call, we just got notified that we got an NCI grant for preventive treatment for high-risk patients. Yeah, so working with Dr. Joe Testa, the guy who discovered the BAP1 gene,
Yes,
using his model, and I can't spill the beans yet, but it's literally just a vegetable-derived compound that you could take every day. I'm hoping we'll see what happens. I'll have an update for you probably in a year or two, what's going on with that. But Dr. Testa has developed this mouse model of asbestos-induced mesothelioma, and we're going to, give half the mice this the gist of the grant is we're going to give half the mice this supplement, which you could just take every day. I'll tell you this, based on the stuff that we did at University of Maryland, this basic science research, I buy it off Amazon. I take it myself. It's definitely my can't hurt, may help file. So we'll see if it makes a difference for mesothelioma, but that's something, I think if you had a high-risk group of patients, not only should we be screening them, but if there was something you could be taking to try and prevent mesothelioma, what a great contribution. I'd love to have, have that be as part of a legacy.
absolutely. Well, thank you so much for being on this with me today. I think that I've learned a lot. I'm sure that our patients have learned an immense amount. And your explanation, your artistic abilities were
you're too kind, and I do mean
we're very
kind.
helpful. So
Okay.
thank you so much.
Well, thank you for having me. I appreciate the opportunity to